Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with fully blocked earwax in this their right ear. And this earwax has been there for a while. You can probably tell by the colour. It's darkened, so it's matured. And as earwax matures, as it oxidizes, it turns from a pale orange colour to a dark brown, almost blackish in appearance, if it's been there for a long time. This patient's main symptoms were really dry and itchy ears, in part due to the wax, but you can also see, particularly at the entrance of the ear, that they do suffer from otitis externa. So otitis externa is an umbrella term given to an infection or inflammation of the outer ear. And this patient's got what we call superficial otitis externa. So the outer layer of skin, so the superficial layer of skin, the epidermis, has become very dry and itchy and flaky, and there's loads of dead skin flakes there. And they do suffer from eczema, and they are receiving treatment for that from their GP, so it may be related to their eczema. In addition, having this earwax in their ear is quite dry as well. Every time you move your jaw, so when you're eating or swallowing or chewing, this wax can rub against the side of the ear canal walls, and that in itself can cause itchiness. There are a few matted hairs against this wax, and those hairs can of course tickle the ear canal as you're moving your jaw. What made this procedure just a bit more tricky than norm is that this earwax is trapped because the entrance of the ear is slightly more narrower, and as you enter the ear and progress towards the eardrum, the ear canal protrudes wider, and as such this wax has filled up the wider section of the ear canal, and we're then having to bring up this widened piece of wax through a narrow entrance, which is always a bit tricky. You can just see there that the entrance is extremely narrow. So I've just used the ear hook that cut and diced the wax into smaller pieces, and I'm just removing some of these pieces using a Jobson horn now. Again, I'm going to stretch the ear open, so I'm using the endoscope to assist me in that. The endoscope, as I enter it in the ear, I push it towards the left-hand side, so the posterior canal wall, and that stretches open the entrance, which then allows me access with the instrument to go in and try to wriggle this wax out. So I've just reverted to microsuction. I'm using a Zollner suction probe. It's a standard size Zollner suction probe. When I say standard size, you can actually you can get Zollner suction probes in slightly variants in terms of the internal diameter, but quite often you'll see me using a fine end. I'll be using one a bit later, and a fine end is an extension to the end of the Zollner suction probe. So it's a friction fit, it's a push fit, and what we attach to the end of the Zollner suction probe is a narrower suction tube, which provides less suction power but also less noise. Microsuction can be noisy. A fine end also is less atraumatic, so if you do come in contact with the canal wall or the eardrum, it's less likely to cause any trauma to the patient. And a bit later on in the procedure, I'm going to be removing some skin. I'm going to be peeling some skin of the ear canal, and a fine end works a lot better than the standard size Zollner suction probe when peeling skin. Not only is it more precise, so when we're working on the ear canal directly or the eardrum, we want that additional precision, and we get that because obviously the fine end is smaller. It's like a fine tip pen or pencil. You can draw lines or images or even write with more precision. But you're less likely to get clarinetting. Clarinetting is when you're suctioning dead skin, this skin violently flaps against the tip of the suction probe, and that emits a very loud, high-frequency squeal. It's not only noisy for the patient, but also myself. One of the things I was pondering the other day is that I have a feeling that many audiologists, or anyone who performs regular earwax removal, may be suspect to developing a bit of noise-induced hearing loss. Not so much due to the suction noise, because that's more towards the patient, and for the patient it's short-lived, but it's more to do with the suction pump, which is beside me. And although the suction pump isn't noisy to the effect where I need to wear ear protection per se, but if you're exposed to it for a number of hours, for a number of days a week, accumulatively, it can potentially cause a bit of hearing loss. And it's similar to having quite a few dental nurses and even dentists who are kind of who are more experienced, senior, coming to the end of their careers perhaps, developing hearing loss. And I know now there's a big push and incentive for dentists and dental nurses to wear ear protection. It can inadvertently affect their performance. I was speaking to a dental nurse of the week and a dentist as well. And also for an audiologist, when we're removing earwax, because sometimes the noise is very beneficial. When I've got a good suction grip, the noise changes of the suction, which then tells me that I've got a good suction grip. And one of the issues, obviously, when you wear ear protection, you may not notice that subtle difference in suction noise. But of course, our ears are much more important in that respect. Eardrum's nice and healthy, just a bit of skin now. We're going to peel that away. I'm going to use the fine end, I think. Let's have a look. Yeah. This skin has slightly been softened already because I already put some olive oil medical grade spray in there. And I'm just going to start peeling it towards the eardrum. I don't remove all the skin. There was a bit of clarinetting, what I made reference to earlier. So we stop then. We don't want to make this procedure make it uncomfortable for the patient by inadvertently deafening them, because it is a very loud, high frequency squeal, believe you me. Even I find it loud, so I have to withdraw straight away. It's quite a tough layer of skin. It's quite thickened. You can see it's really not peeling freely. And just to the front part of the ear canal, because they have got a narrow ear, it does somewhat restrict the ability to me to manipulate the instrument in the ear. I'm not able to make exaggerated movements with the fine end, because if I do and I move the fine end from one side to the ear to the other, I'm likely to make contact with the canal wall. So when you've got a narrow ear, it means that you've got less maneuverability, operational space within the ear canal itself. I think I'm just going to remove a bit more and we're done. That bottom piece I'm going to leave because that was clarinetting. So to that bit just to the left, you can see that skin's just starting to peel away. So I'm just seeing if I can almost tear the skin away. It's not going to come away all in one piece. We just want to tear it away. It's just the end. There we are. That's patient's eardrums. Is a textbook eardrum. Well, I hope you enjoyed that video, guys. Take care. Keep well. Speak soon. Bye.